Welcome to Phase 2. In the modern hospital, treating the patient in front of you and protecting the population around you are no longer separate disciplines. They connect via a continuous pipeline. Our national health programs do not operate on syndromic guesswork. They function as deterministic systems, where precise microbiological data dictates exact public health interventions. We are bridging your microbiology diagnostic competencies with community medicine public health strategies. To understand this architecture, we will trace the data flow for 3 major pathogen groups: mycobacteria, viral infections, and vector-borne or zoonotic diseases. Every positive test from these categories flows upward into the central iHIP portal, establishing a real-time digital surveillance grid for the entire country. Mastering this connection is necessary for your Phase 2 exams, but more importantly, it is the underlying logic of modern clinical practice in India. Let's start with tuberculosis. India operates under an aggressive national strategic plan, ending TB by 2025. To meet that deadline, the National TB Elimination Program shifted away from traditional microscopy. They now rely on upfront molecular testing using CBNAT, or GeneXpert. This schematic shows how the assay targets the RPOB gene, simultaneously detecting Mycobacterium tuberculosis and rifampicin resistance. This profiling takes under 2 hours at the primary center. This turnaround lets clinicians bypass weeks of waiting, instantly initiating daily fixed-dose combinations. A confirmed positive lab result also triggers a secondary community protocol, TB preventative treatment, or TPT, initiated for the patient's immediate household contacts. All of this patient data is logged into the Nikshay portal, which tracks treatment adherence and automatically distributes financial support through the Nikshay Poshan Yojana. While molecular tests drive the initial response, the automated MGIT 960 liquid culture remains the gold standard for full phenotypic drug susceptibility testing. Without rapid, automated molecular resistance profiling deployed at the primary care level, hitting a 2025 elimination target would be mathematically impossible. Leprosy presents a very different diagnostic reality. This labor-intensive physical diagnostic process forces the National Leprosy Eradication Program to rely on active case detection campaigns, conducting door-to-door screenings in the community. When a case is found, close contacts are administered a prophylactic single dose of rifampicin. The confirmed patient is then placed on a uniform 3-drug multi-drug therapy: rifampicin, clofazimine, and dapsone. A pathogen's intrinsic biological limits directly dictate whether a national program can rely on automated lab screening or if it must mobilize active physical surveillance. We see another constraint in viral diagnostics. For adult HIV diagnosis, the NACO Strategy 3 algorithm mandates 3 distinct consecutive antigen or antibody tests to confirm a positive result. The 4th-generation ELISA is the critical first step because it simultaneously detects the HIV antibody and the viral P24 antigen. Early infant diagnosis introduces a biological complication. Maternal anti-HIV IgG antibodies actively cross the placenta into the fetal bloodstream, persisting up to 18 months. This renders standard antibody tests invalid. The workaround requires a direct molecular approach, an HIV DNA PCR test on dried blood spots. This specific DNA PCR testing protocol must be initiated exactly when the infant reaches 6 weeks of age. These rigid testing algorithms generate the precise data required for the NACP Phase 5 target of diagnosing 95% of all infections. Once the lab confirms the diagnosis, the ultimate policy goal is to provide universal access to a single-pill daily regimen, the TLD antiretroviral therapy. Similarly, quantitative PCR diagnostics for hepatitis B and C trigger the National Viral Hepatitis Control Program's rollout of free 12-week direct-acting antivirals. Because of the mechanics of maternal biology, the state must build an entirely distinct diagnostic pathway to achieve its pediatric elimination targets. Let's look at virology in the context of global elimination. Polio acute flaccid paralysis surveillance demands the collection of 2 stool samples, spaced 24 to 48 hours apart, within 2 weeks of onset. Transporting these samples requires a strict reverse cold chain, constantly maintaining a temperature between 2 and 8 degrees Celsius.
At the reference lab, the samples are inoculated into specialized RD and L20B cell lines. The L20B line is utilized specifically because it is genetically engineered to express the human CD155 poliovirus receptor. That rigorous laboratory protocol provided the exact surveillance data required to certify India as polio-free in 2014.
The National Rabies Control Program is attempting a similar feat, targeting zero dog-mediated deaths by 2030. For Category 3 exposures, begin with a 15-minute wound washing with soap and water. Suturing is absolutely contraindicated. This is followed by the intradermal updated TIE vaccine schedule on days 0, 3, 7, and 28, plus local rabies immunoglobulin infiltration into the wound. Achieving a zero-death target relies entirely on flawless, immediate clinical protocols executed the moment a patient walks into a primary care center. Every algorithm, diagnostic standard, and clinical protocol we've discussed is governed by a strict hierarchy of Apex National Reference Laboratories. These institutions anchor the entire system. ICMR-NIRT in Chennai regulates tuberculosis diagnostics, while NARI in Pune oversees HIV. The ICMR National Institute of Virology serves as the apex laboratory for arboviruses and viral hepatitis. The NCDC manages polio surveillance, JALMA handles leprosy, and NIMHANS sets the standard for rabies control. Thousands of microbiologists across the country continuously feed their confirmed lab data into the L format of the iHip digital portal. The L format data from the lab merges with the S format syndromic reports and P format presumptive clinical data, creating a comprehensive real-time surveillance web. In modern Indian healthcare, accurately diagnosing a single patient at the laboratory bench provides the exact data points that calibrate the algorithms, saving the broader population.